Today's lecture is a history lesson, but first I think it's always important to define your terms. So you know what slow march is, but when I talk about high-value healthcare, I'm really talking about the relationship and the ratio from healthcare quality, patient experience, and service relative to the total cost of care. And I don't need to convince anybody in this room about physician ownership for quality, safety, experience, and service, but I don't want anybody to walk away feeling that we don't have a comparable ownership to the cost of healthcare as well. And we own it in part because while we only account for less than 15% of all of the $3.1 trillion a year in healthcare spending, we make the decisions that directly or indirectly steer the other 80% of costs. It's increasingly clear, both with natural experiments and over time, as healthcare deductibles go to $3,000 and $4,000 and $5,000, that patients go without healthcare when they can't afford it, and because very few individual patients know what's important and what's not important, they go without important things, not just elective facelifts. And then finally, it's increasingly clear both in the government sector and as individual patients and their families make decisions that as healthcare becomes increasingly unaffordable, they go without other things, whether it's education or other things that drive their well-being. So my talk today is not surprisingly heavily skewed by my own lens, and having spent the last 25 years really in high-value healthcare, in coming at that overarching theme from a variety of perspectives. For most of my career as a practicing surgeon, as an academician focusing on the phenomenon of variation in quality and safety in surgery and later in costs. I spent the mid part of my career, as Dr. Hahn alluded to, at Michigan, not just as a leader of a research institute, but working in pretty close partnership with a very innovative, very large value-based purchasing network run in partnership with Blue Cross and Blue Shield of Michigan. And then finally, in the most recent phase of my career, I've segued out of academia and more to the executive side of the fence, first leading clinical operations in a large integrated academic health system, and more recently in a national physician practice that is very much on the avant-garde of managing to so-called value-based payment models. I've been very blessed over the last 20 or 30 years in having had the opportunity to serve in lots of interesting roles, and a lot of that success comes from my willingness to take risk, but a lot of it comes from dumb luck in a currently, and occasionally as a direct consequence of failure. How I first got into health services research, I think, is a good allegory for how failure can drive success. It was 1989, and I was a fourth-year medical student at Harvard Medical School, and I think it's fair to say that I really had no clear direction for what I wanted to do with the rest of my life. I spent way too much of my time partying with my former friends from Boston College rather than engaging at Harvard Medical School, and I think it's fair to say that I took slackerdom to a new height at Harvard Medical School. But it was in the third week of March in my fourth year of medical school where I came back a day or two later than I had planned from a trip to New York, and I got into my dormitory in Vanderbilt Hall on Monday night, and it happened to be the Monday night 2 days before the match. And when I got into my dorm room, the voicemail was like blinking red. There was like 6 messages from the dean's office, and it's not a good sign to have lots of messages from the dean's office 2 days prior to the match. And what I learned the following day was that I had failed to match in general surgery. Do you know how hard it is to not match in general surgery out of Stanford or Harvard Medical School? So that just speaks to my level of talent. Well, it turned out that by the time I got back to the dean's office the next day, I had missed what's called the scramble, which is where you make telephone calls and you find something outside the match. And kind of what was left for me at that time was a categorical general surgery slot in Maine Medical Center in Portland, Maine, or a prelim role at Dartmouth. Had never been to either place, didn't know a single soul at either place, and I made a couple of phone calls and I essentially flipped a coin and essentially wound up as a prelim general surgery resident at Dartmouth. And little did I know that I was walking into the home of Jack Wenberg, really the godfather of health services research and health policy. And Jack had really come onto the, had really exploded the scene in the early 1970s with a seminal article in the journal Science describing how use of healthcare services, in that case hysterectomy and tonsillectomy, varied as a function not of patient need, but function as a simple matter of where patients lived. He, of course, went on to found the Dartmouth Atlas of Healthcare, which was not only very influential in the founding of the Affordable Care Act and a lot of the things that we live with today, but was a big part of my own academic upbringing. So what I'm going to do over the next 30 or 40 minutes is describe my own perspective on the last 30 years of how research, policy, health reform have conspired to take us incrementally to high-value healthcare. And I'll describe it in terms of the initial thrust and focus on quality and safety, the transition to so-called pay-for-performance around the turn of the millennium, and then kind of where we are now, which is squarely in the jaws of so-called value-based payment models, which have implications for everybody in the room. So the quality and safety movement, particularly in surgery, but more broadly than surgery, kicked off a little bit before my time and most of your time. In 1984, there was an incredibly high-profile medication error in snafu that played out in New York. Libby Zion, a young student, died, was battling with depression, was given the wrong medication, died, and it happened that her father was Sidney Zion, a very prominent editorialist for the New York Times. Her tragedy, the death 2 years later of Andy Warhol by what was reported then to be uncomplicated gallbladder surgery, led this very substantial outcry within the lay media about the phenomenon of safety in hospitals and medical errors. Those two cases ultimately got the train rolling for what is now the 80-hour work week and led to this burgeoning body of research looking at the comparative performance of hospitals and physicians. And among the many, but among the most seminal of these studies, were articles profiling the extent to which, after adjusting for case mix, there was wide variation across both hospitals and surgeons with regards to open heart surgery, both in New England and in New York State. And then finally, most of you are familiar with what I'll call the research capstone of the medical errors in the hospital safety movement, which was To Err is Human, being published in 1999, and at the same time, the surgical version of the Harvard practice study by a then relatively or very much unknown Untitled Chapter, pointing out that not only were upwards of 100,000 patients dying a year as a result of medical errors in hospitals, but upwards of half of those adverse events and deaths were occurring in surgical patients. So my own entree into research obviously was abetted by winding up in Dartmouth and all of the direct and indirect effects of Jack Wenberg, but I also realized that I had landed in the home of a bunch of pissed off heart surgeons, which, as most of you know, does not take much. So it turns out in 1987, HCFA, then the Healthcare Financing Administration and the overseer of the National Medicare Program, had begun to go public with claims data-based mortality profiles of hospitals and surgeons. And as luck would have it, Dartmouth was very much on the wrong side of the median. They were in the bottom 10th percentile nationally, and they were the lowest ranked heart surgery program in New England. Steve Plume, the chief of cardiac surgery, was convinced that this was a function of bad data, that CMS wasn't adequately accounting for the fact that his and their patients were older and sicker than everybody else's. So he and Jerry O'Connor, and a group of epidemiologists, cardiac surgeons, interventional cardiologists, and other team members began to prospectively collect detailed clinical data on every patient undergoing both open heart surgery and interventional cardiology. Their work would subsequently go on to fuel that seminal article that I pointed out a couple minutes ago in JAMA, showing that at the end of the day, when they had collected their first 5,000 or 6,000 patients and had better data for risk adjustment, that HCFA had basically gotten it right, that there was in fact a threefold spread in mortality across the then 5 hospitals in New Hampshire, Vermont, and Maine that were doing cardiac surgery, but there was even more variation across the 18 operating surgeons. So this is a copy and paste slide from that 1991 article in JAMA, and you see going across the horizontal axis, the 18 operating surgeons you see on the vertical, of course, they're unadjusted and the risk-adjusted mortality rates for isolated cabbage, and there was, give or take, a 5-fold spread. So I was sitting in the fall of my internship year in an amphitheater very much like this one, and I heard Steve Plume give the first public airing of these data. And this slide and the data that attached to this slide, to me, was just this epiphany, like that there was this much variation. We didn't realize it was there, and we didn't know what was causing it. So I made an appointment to meet with Plume, to meet with meet with Dr. Wemberg, and others. Applied for, got a NIH-funded fellowship that was based at Dartmouth, and that's where I did my 2 years of research training between my second and third years of surgery. Well, it turns out that just before I initiated that research fellowship, I had the opportunity, shall we say, as a second-year resident, to be on the cardiac surgery service. And this was, of course, back in the days where clinical service took precedence over educational needs of residents. So I was on call every other night, first assisted every other pump with the third-year resident because we didn't have fellows, PAs, or other folks assisting them. So it was fun, but it was grueling. And by the end of this 5 months, I had a very clear sense about, the 3 operating surgeons to whom I would send my father if he were ever in need of coronary artery bypass surgery. There was one surgeon in particular that was very articulate with regards to who he operated on, why, was very efficient and slick in the operating room, and seemed to have a pretty structured approach to how he managed care after surgery. Well, it turned out that, as I became a research fellow a few months later and I got confidential access to these data, that this is who I would have sent my father to. And I think that it speaks to my own credibility as a scholar in quality. But more importantly, it does, it indicates that I'm not as close to my father as I would hope to be. So in that period from the 1990s to the present day, there's really been 3, large-scale thrusts aimed at improving quality in surgery and improving safety. Volume-based referral is, one that is very close to me personally because it's very close to the, to the earliest phase of my own research, and it's very close to some of the early work that I did with Arnie Milstein here at Stanford when Arnie, Bob Galvin, and others were launching this big consortium of healthcare purchasers looking to leverage volume alongside other quality indicators in steering patients to centers likely to have the best outcomes. In a paper that I wrote with my former Michigan colleague John Finks, it's very clear in retrospect that over the course of the aughts in that decade, between some of the early research papers in the launch of the Leapfrog group that there was a substantial trend towards market concentration, particularly with regards to some high-risk types of procedures. So over the decade between 1999 and 2008, the median hospital volumes associated with some of the most volume-sensitive operations, surgery for pancreatic cancer, surgery for esophageal cancer, went up by a factor of 2 or 3-fold. At that same time, there was, in relative terms at least, a give or take 20% decline in risk-adjusted rates of mortality, while not shown here across these same procedures across all of the 1990s. Those rates were entirely flat. And with the application of some sophisticated econometric metrics models, it became clear that when you tried to disaggregate what was driving trends towards declining risk of mortality over the decade of the early aughts, what became clear was that, as you see on the right-hand side of this slide, that give or take 1/3 to 2/3 of that overall improvement could be directly attributable to more patients undergoing surgery in higher volume hospitals. Interestingly, however, on the bottom half of this slide, notice that there was no volume-driven trend towards improving mortality with cardiovascular surgery, in part because cardiovascular surgery is less hospital volume sensitive than is cancer surgery, but also in part because there was this proliferation of cardiovascular hospitals across that same time period, and there was no significant trend towards increasing volumes anyway. So the second big trend that happened, starting first in the early 1990s with the proliferation of the STS database in cardiothoracic surgery, what was then called the UNOS database with organ transplantation, and originally starting in the VA hospital with the NSQIP program for general vascular surgery, there was this major push to get performance measurement and performance feedback into the drinking water of our professional societies, ultimately culminating in the VA-based NSQIP program migrating over to the American College of Surgeons in 2004. Now, I have historically been a big believer in the so-called Hawthorne effect, that the simple act of measurement has a salutary effect in making outcomes better, including in surgery and in otherwise. And a lot of my own biases with regards to that belief were born out of my early work as a fellow with the cardiac surgery group. In northern New England, rates of mortality fell further and faster than in any other part of the country, and a lot of it was the basic blocking and tackling associated with identifying what works with data and otherwise and getting it diffused into practice. But interestingly, the single biggest drop that occurred with regards to mortality rates across those same 5 hospitals that I described earlier occurred almost instantaneously after risk-adjusted mortality rates started to be fed back both to the hospitals and confidentially to the operating surgeons. Subsequently, there was data from a variety of sources, but including from the VA-based NSQIP program that showed that within 2 years of the initial launch and the initial feedback of hospital performance data, that rates of complications across general vascular surgery across the Department of VA Health System fell by a staggering 41%. I have to say, though, that my belief of a surgical Hawthorne effect and the belief that improvement occurs solely as a byproduct of measurement and feedback, though, was shaken by a couple of very visible follow-up studies. One of these studies was published by David Etzioni out of Southern California, but the other was by Justin Dimmick et al. From some of my former colleagues from the University of Michigan. Both of these programs leveraged different sources of data, but ultimately what they did was they identified the entire national cohort of hospitals that were participating in the ACS-based NSQIP program, identified a group of control hospitals that looked just like them but did not make the investment in the NSQIP program, and then assessed not only their baseline risks of performance with general vascular surgery, but how fast they improved over time. What they found, and both of them found the same thing, was that hospitals that elected to participate in the NSQIP program started out with better outcomes than those that opted not to. So there's some type of selection bias driven by sort of the commitment or the motivation to quality associated with that investment. But interestingly, and I'm not going to walk you through the data, rates of improvement for those that began a process of getting rigorous feedback about their hospital and their operating surgeons were completely non-distinguishable from their peer group of hospitals that were not part of the NSQIP program, prompting Don Berwick, the former head of the CMS program, who wrote the editorial in JAMA attached to this, to quote the African proverb, "Weighing the pig doesn't make the pig fatter." My own take on the so-called Hawthorne effect is that performance feedback alone is likely to be impactful when it's measures that are targeted at individuals, when they're credible, and when they tie to measures that are directly actionable. So finally, let me close out the quality and safety movement with the third major pillar of at least the surgical safety movement, which was the movement towards operative and perioperative checklists. Over a flurry of about 5 years, there were three very seminal articles, each one of which was in the New England Journal of Medicine, and two of them reached very similar findings and ran counter to the findings of a third. So the first article was the famous WHO study that was anchored by Atul Gawande. 8 hospitals, 8 cities, 4 in the developed world, 4 in the developing world, and this study was very simple. It was a before-after study comparing outcomes in the 6 months prior to implementation of a 19-item operative checklist to outcomes in the 6 months after implementation of the checklist. The results were really staggering. Mortality rates fell by half. Complication rates fell by a third. I was a reviewer of this study, and there was some basic face validity questions associated with anything that could make surgery that much safer, much less the types of things that were actually on the checklist. And the thing that also didn't ring true to me was that, if you looked really careful, there was zero correlation between whether hospitals actually did what was on the checklist and whether their outcomes got better. So for example, in that study, the 2 hospitals whose compliance with the items on the checklist improved the most were the 2 hospitals whose outcomes didn't budge. And similarly, the 2 hospitals on the other side of the spectrum who basically didn't change anything about their compliance level. One hospital in the first world was 99% compliant with the checklist prior to the study and was similarly so afterwards. The other was compliant 0% of the time prior to the checklist and 0 afterwards, were the hospitals whose outcomes improved the most. So I got asked to write an editorial, and I remember saying, unfortunately, the results seem too good to be true. Literally 1 year later, the SURPASS study was published. This was based in Scandinavia, much larger than the WHO. The checklist was a little bit different to the extent that it wasn't just an intraoperative checklist. It was a checklist that encompassed handoffs from the operating room to the PACU and from the PACU to the wards. And when compared to the WHO study, it was not only larger, but it had a control group of hospitals that weren't part of the study, showed improvements that were almost as large as the WHO studies. The improvements were much larger in the checklist hospitals than in the non-checklist hospitals. And interestingly, among the checklist hospitals, those that were more compliant with what was on the checklist had better outcomes than those that were less compliant. So I had to eat crow, and I wrote the editorial for that particular study, and I said, checklists should now be considered standard of care. Fast forward a few years later, David Urbach, again in New England Journal of Medicine, wrote up a natural experiment from the province of Ontario, Canada, 101 hospitals, and he described what happened when the province mandated that every one of those hospitals implement an operative checklist for every single operation done under anesthesia in the province. Huge sample sizes, but as null as null could be. And I stopped writing editorials at this particular time. So I think it's safe to say that the jury is still out about how big the overall effect is of checklists, what it is about checklists that is most impactful, and how they could be better. So pay for performance. So pay for performance really kicked off in the commercial insurer sector, generally around 2000, 2001, 2002. The Leapfrog group, which I described earlier, was part of the avant-garde of that effort, but the basic policy intervention at this point, which was squarely focused on improving quality and safety, was basically implementing a variety of carrots and sticks. Mostly carrots in the early implementation associated with physicians and hospitals being adherent to a small list of evidence-based practices. And everybody in here knows kind of what the short list is for those types of processes for surgical care, prophylactic antibiotics for SSI prophylaxis. Making sure that the patient gets the right antibiotics within 59 minutes of surgery, and that they're ceased within an appropriate period of time. VTE prophylaxis, et cetera, et cetera. Unfortunately, at least with regards to these process-based quality indicators, there was very little indication that that implementation of these programs, either by commercial insurance or ultimately by CMS, had a big effect in terms of moving the needle. By far, the biggest, most visible pay for performance program was the Premier Demonstration Project. And as you can see from this slide, Terry Shih, formerly a fellow with us at the University of Michigan, looked at the implications of pay for performance in CABG and in hip and knee arthroplasty. And as you can see from the right-hand side of the slide, there was really no independent effect once you adjusted for secular trends and you compared the P for P programs with the non-P for P programs on rates of mortality, risk of any complication, or risk of serious complications. I think the take-home point here is not that evidence-based practices aren't important, it's that surgical care is complicated, and the association between any individual process and and rates of end outcomes are oftentimes a lot weaker than you would guess, and a lot of Dr. Hahn's earlier work has shown the same thing, particularly with regards to SSI. Ashish Jha, a researcher from Harvard, basically used the Premier study as well and demonstrated what I just showed you in surgical care, showing that in non-surgical hospital medicine that there was very little associated with the P for P processes and rates of mortality. And then finally, CMS, as is its want, was aware of some of the null findings of the earliest pay for performance programs, but it's been largely undeterred in moving forward with both physician-based and hospital-based pay for performance programs. Most of you know on the physician side that CMS is quickly moving out of what used to be pay-for reporting, so-called PQRS, and is now on a slightly delayed but still moving forward timeline for implementation of so-called MIPS. MIPS is basically pay-for performance attached to professional reimbursements for physicians, but will increasingly be tied to a small number of accredited measures that are attached to specific specialties. I'm sure you've heard a lot about that, and we'll be hearing more about that. On the hospital side, your hospital, just based on my sense of its size, probably has $15 million a year at risk for hospital pay for performance metrics. Probably 2/3 of that is for its readmission rates and for so-called HACs, hospital-acquired conditions, both specific types of adverse events and infections. The hospital VBP, value-based purchasing program, is that holistic measure of hospital quality that patients can see when they log on to the CMS Hospital Compare website. And that program and that particular measure is based on a composite of compliance with process measures, risk-adjusted mortality with 6 of the most common things that hospitals manage, experience, and a couple other measures. But echoing some of the results of the early P4P studies, there's really not a ton of evidence that even the current generation of P4P programs is moving the needle on quality, at least if you judge quality by the end results measured. So Justin Dimmock, again with economist Andy Ryan, had a very important paper that was published almost exactly a year ago, showing how there's essentially no association between how hospitals do with these composite ratings and their mortality rates, or the rate by which either mortality or other types of quality indicators improve over time. Okay, let me segue into kind of where we are right now. And when I say where we are right now, it's value-based payment models in the wake of the Affordable Care Act. Most of you know that the Affordable Care Act, aka Obamacare, now is in its 8th year. Obamacare really did 2 things. The first and arguably the most important thing that it did was it expanded coverage via the exchanges and expansion of funding for state Medicaid programs. That is the half of Obamacare that's currently under siege, as you know, or at least had been under a siege until a couple months ago. But the less recognized but arguably equally important byproduct of the Affordable Care Act was the launch of the Centers for Medicare and Medicaid Innovation, which was really the administrative agency in the Innovation Center for attaching reimbursement for health care to various aspects of quality, cost, and ultimately value. So what drove this component of the Affordable Care Act was the observation that is familiar to everybody in this room, that healthcare costs in the U.S. have grown, are not only substantially higher, at least as a fraction of gross domestic product, than our peer developed countries, but are also growing faster. It was driven in part by some of the seminal work done by the Dartmouth Atlas of Healthcare Group and echoed by others, showing that there were very substantial, very unexplained disparities in rates of healthcare spending, largely a function of where you happen to live. Adjusting for case mix, focusing exclusively on Medicare fee-for-service patients, if you, in 2006, lived in the referral area of Minneapolis, your average per capita spending was about $6,700 per Medicare patient. If you lived in Miami, for a similar cohort of patient, the total spending was about 2.5-fold higher. And then finally, and a very seminal dyad of articles that may have flowed under the radar of academic surgeons were a couple of studies published by one of my former mentors, Elliot Fisher. Elliot now succeeded Jack as the director of the of the Dartmouth Atlas, but he, along with Mark McClellan, the former head of CMS, were the co-branders of the term accountable care organization. Well, Elliott published 2 articles that were published in the same issue of Annals of Internal Medicine, where they tried to relate regional variation in total healthcare spending to various outcomes for patients. So they took the 306 regions of the country defined by the Dartmouth Atlas of Healthcare. They ranked them from least expensive to most expensive, grouped them into quintiles, so evenly sized groups of regions, and then they did very deep dives into various types of outcomes. And what they found was the following, was that if you compare high spending areas as compared to either median spending or low spending areas, that A, there was no evidence after risk adjustment of gains in survival or better patient functional status. When you do random but rigorous surveys of physicians living in high spending and in low spending areas, those physicians that practice in high spending areas reported paradoxically worse communication, worse coordination of care, and a perception of scarcity. And then finally, when they surveyed patients living in high spending and in low spending areas, those in the high spending areas reported lower overall satisfaction with their care and worse access. So that ultimately got to the cost conundrum, that very influential article by Atul Gawande that was famously reported to be on Obama's nightstand, was very influential as both parties negotiated on what was to be ultimately become the ACA, and ultimately how population payment models were framed, and particularly accountable care organizations. So accountable care organizations, the basic framework is a group of caregivers, hospitals and physicians and others, basically agree to share responsibility and accountability for the care of a defined population of patients. There's, as with anything, an alphabet soup of different types of accountable care organizations. There's, give or take, almost 1,000 what are called Medicare shared savings programs. But the real accountable care organizations that have gotten the most press used to be called Pioneer ACOs, and now have been rebranded with some change in the underlying policy to be called Next Gen ACOs. But the basic deal is that these accountable care organizations are expected to meet or exceed a defined array of quality metrics for the population they serve, and to meet certain benchmarks in terms of population spending. Basic business model for ACOs is as follows. CMS basically uses historical claims data and defines what trajectory your population-based spending is for your health system or your ACO. They basically say, we would like you to, quote unquote, bend the cost curve by this degree, and then to the extent that you are successful in driving actual payments below that expectation, you get to you get to keep or at least share the delta between the spending benchmark and your actual payments. Probably the most visible study that's assessed the early results of accountable care organizations came from Mick Williams in the Harvard group, was published in New England Journal about 3 years ago. Interestingly, the take-home point of this study was that ACOs, adjusting away all the noise and taking just the overall aggregate effect, reduced overall Medicare spending by about $100 to $200 per patient per year. Since the average spending for a Medicare patient is about $10,000, that's about a 1 or 2% decline per year. Interestingly, if you look at some of the fine print in this plot, almost all of the savings accrued in ACOs whose spending was starting out at or significantly above the national average. So there was some degree of regression to the mean. There was very little success among any ACO whose baseline spending was starting at or below the national median. So this is so ACOs are fairly close to my heart, and it's a significant personal pain point for me. So, so Dartmouth-Hitchcock, so I was at Dartmouth-Hitchcock and was executive vice president for clinical operations for several years. Dartmouth was one of the very early pioneer ACOs. There were only 32, and ultimately half of them left by the time that the program ended a couple of years later. Dartmouth jumped into ACOs partly for ideological reasons. This part of the country is not only where Bernie Sanders is from, but it's where Dartmouth Atlas and Elliot Fisher actually coined the term ACO, so there was some need to be part of the avant-garde there. There was also some belief that there was a strategic advantage to Dartmouth-Hitchcock being part of an ACO. Dartmouth is, give or take, located about 2 hours by car northwest of Boston, and located about exactly halfway between the city of Boston and Hanover, New Hampshire, is the most population dense part of New Hampshire, and where the Boston programs and Dartmouth-Hitchcock compete for patients. There was a strategic sense that it was hard for Dartmouth-Hitchcock to win that battle because we're bigger, we're more famous, we have better doctors, but there was some hope that, to the extent that Dartmouth-Hitchcock was starting with much lower per capita spending per patient than its competitors in the South, that that getting an early foothold, first in ACOs and in the capitated health plan, would ultimately help them enlarge the population they served. Ultimately, that never proved to be true. It never proved to be true because the march from accountable care organizations to capitation moved a lot more slowly than anybody thought that it would. And ultimately, Dartmouth-Hitchcock had to pull out in a somewhat public failure because it couldn't afford to be in an ACO. The administrative overhead for the system associated with being a pioneer ACO was about $12 million a year. And on top of that privilege, despite on top of that, Dartmouth was losing about $5 million a year in penalties to CMS, despite being in the bottom 10th percentile of overall spending. It ultimately was, was successful because it's hard to improve when you're already starting at a very low level of spending, a fact that should be obvious to anybody here but wasn't fully appreciated at the time that the decision was made to make that plunge. It was also, aside from just making the math work, it also was very interesting for me, as direct experience in the so-called two canoes problem. In my own role, there was, a pretty palpable paradox in being able to, in overseeing primary care and basically trying to implicitly or explicitly send the message, less care, less hospitalizations, less referrals to specialists, while at the same time talking to the surgeon and say, operate more, operate more, operate more. And interestingly, when you actually looked at what it meant for the health system, for us, it was less a two-canoe problem, but more a one canoe with a big dock problem, in that population health payments were a conceptually important thing, but really kind of the upside downside for us was measured in like low tens of millions, but the fee-for-service part of our enterprise was measured in billions. So, so ultimately, we'll see where next-gen ACOs go. I think the single most important evolution that has occurred is that next-gen ACOs lay out a clear pathway to not just shared savings, but to fully capitated payments for care, which will really change the game. So the last payment model that I'll share with you is, is taking one step back, and that is episode payment models. Even though it's, even though it occupies a middle ground between so-called pay for performance and population-based payment models, it's really where a disproportionate thrust of CMS-based policy is right now. It's also something that is a big focus of what I'm doing personally. So episode payment models are a simple concept. A health system or hospital or physician group accepts a fixed payment, a so-called target price for all of the services that are delivered around an episode of care. Typically, an episode of care can be defined by a diagnosis, but it usually is defined by a hospital stay. The two most visible programs right now are the involuntary episode payment model for joint replacement called CJR. That same program was supposed to be extrapolated out to open heart surgery and a number of other common types of conditions, but the Trump administration has put the brakes on that. But the much larger episode payment model is BPCI, so-called Bundle Payment for Care Improvement Program. So BPCI mechanics, I'll give you a schematic that's analogous to what I described for ACOs, but a little bit different. Basically, CMS takes a 3-year run rate for what your historical spending has been for that particular specialty or group of DRG bundles. It asks you to take a fixed discount, and the discount that they ask for right now is a 3% discount relative to your historical spend. And they say, if you're successful in driving down actual payments, we will let you keep all of the savings between that target price and the actual payment. So the business model is pretty simple here. There is a ton of variation around episodes of care, both in acute care medicine but also in surgery. This is a study that I published with my colleague David Miller a few years ago that looked at variation in actual payments around episodes of surgical care. I'll focus your attention just on one of them. If you look at isolated CABG, if you simply sort every one of the hospitals that does that procedure from most expensive to least expensive and to group them into quintiles, the delta between the least expensive and most expensive is about $23,000 per episode. Now, a lot of that spread is because patients undergo that surgery in different parts of the country that have very different regional wages, prices, and cost of living. It's more expensive to have CABG in New York or in the Bay Area than it is in Mississippi. But even if you take price and you take case mix out of the equation, there still is an upwards, depending on what procedure you're talking about, a $5,000 to $10,000 spread in the cost of surgical episodes. So Dunnett et al. In JAMA published the first evaluation about the net effects of the CMS bundle payment program for major joint arthroplasty, and the net effect was that compared to a control group of hospitals that were not participating under BPCI payment models, that the average spending per episode fell by about $1,000 per episode, or about 4% of the overall cost of care. I'll let you judge about whether that's a significant gain or it's not a significant gain. So segue into what I'm doing now. So I am the Chief Clinical Officer of Sound Physicians. And Sound Physicians is a national physician practice specializing in acute care medicine, emergency medicine, hospital medicine, and critical care. We manage approximately 250 hospitals, approximately 20 of which are within about 100 miles of here. And the basic value proposition for sound physicians is not just helping hospitals with their physician staffing needs. It basically is performance management and serving as partners for hospitals in succeeding under episode payment models. So, what Sound does is, is establish contracts with hospitals and helps, establish win-win partnerships around both quality and total spending around acute episodes of care. A lot of what we offer and sell is on the left-hand side of the equation with regards to the traditional services that play out during the patient's index hospital stay. A disproportionate focus of what we do is focused on the right-hand side of the equation, which is post-acute care, which is not nearly as sexy, but from a total cost of care point of view, it's where all of the action is. So about 3 years ago, the Institute of Medicine did a secondary analysis and brought together a high-level expert panel to evaluate the Dartmouth Atlas work. They confirmed their main findings, but had a secondary but really important point that upwards of 80% of all of the regional variation in total spending by geographical region was attributable to post-acute care. So, so as we think about reducing post-acute care, there's, it starts with the basic pillar that, that discharging patients to the best possible next site of care in the best possible outcome is ultimately at the hands of physicians. Driving physician behavior change is a function of the right internal and external motivation. Sometimes it's financial incentives, but a lot of it is messaging around how goals of care discussions and other aspects of transitional care are the single most important thing that hospitals need to do. We have specially trained people both in the hospital and afterwards that make sure that people go to the best possible place after discharge, and we use data and technology ultimately to help physicians make better choices. So for example, in the same IT platform that sits on top of Epic, Cerner, and all of the other IT systems that our hospital partners have, we have a technology platform called Sound Connect that not only deals with the necessary functions of physician charge capture, but also ensures that patients very explicitly are considering the risk profile of those patients, their comorbidities, their likelihood of expiring within the next year, and triggering all sorts of prompts with regards to the use of advanced care planning, use of palliative care.